Hi, Mike Gibson coming to you live from SCAI 2017, and I'm joined by Ted Feldman and Maya Guerrero. We're talking about mitral valve repair and replacement. You guys have a very busy program. Tell us about all the options that are out there, and how do you make the choices, Ted?
We do make choices, and I thought a really great way to frame our conversation would be in terms of the discussion that Myra and I have virtually every day as we sort through these very complicated patients. I think when you come to a meeting, you hear sessions where people talk about repair and replacement, and they're very global, and we talk about all the devices. But our reality is one approved device, MitraClip, in the catheter world of mitral repair, and then a whole bunch of trials that have very severe anatomic and trial selection criteria. And I thought a discussion of how
and many patients may not fit into those criteria, right?
Many don't. They may fit into European practice, but in our world, in the United States, not so much. And the typical starting point is a referral for MitraClip. This might be an older patient, multiple comorbidities, elevated STS, predicted risk of mortality, and one of us gets a stack of CDs and about this much paper, and we see first thing, for example, that it's functional mitral regurg, which is off-label for MitraClip in the US. And then the next discussion is
other therapies. And the other thing that we need to mention is that the risk, not just not all the patients that we get they're referred to us have high risk. So sometimes we get a stack of papers, like you said, and the STS score is actually very low. They come to us, they're younger, and we do try to follow the guidelines. So transcatheter therapies are only approved, or we only have one device approved for patients who are not good candidates for surgery. And we do apply the team approach and discuss with our surgeons, and sometimes we do offer those patients surgery. But once we define or confirm that the risk is high, then we start looking at what is that they qualify for. If they are good candidates for a therapy that is FDA approved, then they can have that. If not, we do not perform off-label procedures. We try to support clinical trials. So if it's functional MR, we have a clear discussion with the patient about the lack of evidence at this point that doing an intervention to the mitral valve is going to have a significant outcome, and we do offer them participation in clinical trials, and we do favor randomized clinical trials. So that patient would be encouraged to participate in co-opt if meets the criteria for co-opt. If for some reason does not meet the criteria for co-opt, as you know, there are early feasibility transcatheter mitral valve replacement trials that are not randomized at early feasibility, but therefore the patients would get there. We wouldn't offer a replacement first. We would start with a repair option if that is a good option for the patient.
Right.
Well, one of the things that has been part of the discussion of the development of catheter valve therapy from the beginning of the pulmonic era, which was really the first, is that people with a prior surgical valve that's failing are in many ways an ideal substrate for this next wave of therapy. So this is one group where we have, still in trials, but we have what we think is a pretty good answer, the valve in valve.
How many people have been enrolled now in some of these mitral valve replacement percutaneous trials?
Well, not many.
Not many.
If you combine them all, we do have in the U.S. maybe 3 or 4, including the mitral, trial, which Ted was referring to, also involving patients with valve in ring. I think we probably are in the couple hundreds probably around the world. We at our institution, we participate in 2 trials, the Tendyne trial for replacement that has enrolled more than 50 patients, and the mitral trial, which has the 3 arms, the MAC arm, native arm with mitral annual calcification, the valve in the valve in ring, that has enrolled more than 50 patients also in that trial. So still not many patients.
And where are we with the anticoagulation following these percutaneous replacements?
This is a extremely difficult area, and we've got our toe in the water with TAVR, where we know that valve thrombosis affects 20% or so of tissue valves, and a population where anticoagulation has a bleeding penalty that could offset this the benefit of treating everyone. So we, as you well know, we have several trials in TAVR with different anticoagulation strategies. We're not even scratching the surface on mitral, except to say that we have to anticoagulate them for at least several months after therapy.
Right.
The other thing that we have coming is a next wave of repair devices. So we have MitraClip approved, but we have a trial for the Cardiac Dimensions Carillon that is approved and in the startup phase, and we're anticipating IDE trials for the Cardioband and the Pascal device, which is a sort of next-gen type double-edge repair device. So the pathway through all of this is getting increasingly complex for now.
As always, right? Great. Well, guys, thanks for taking time out. Thanks for joining us, and thanks to all of you for joining us here live from SCAI 2017.